is Megan Passano. I am the program manager for the CDC-funded CORE SIP grant. So that is the CORE State Injury Prevention Program with the Georgia Department of Public Health Injury Prevention Program. I am also the statewide fall prevention task force lead. I've been of the task force for about 4 years now, maybe a little over. So happy to be here and be part of the training today. Now I will pass it back over to Mia.
Thanks, Megan. Thanks, Jill, for introducing yourselves. I also wanted to give Joshua a second to introduce himself. He's going to be helping facilitate the session as well, kind of behind the scenes.
Hello, my name is Joshua Parker. I'm a second year EPI student at Emory with the pleasure of being the GRA for the Injury Prevention Research Center.
Thanks, Joshua. Joshua has helped with all of our falls prevention efforts, so he's a really important part of the team as well. All right, so some of y'all might be new to the Georgia Falls Prevention Coalition. We also call it the Falls Prevention Task Force, so you might hear me kind of using those two names interchangeably. They do mean the same thing. So we do a lot of things over at the Falls Prevention Task Force. It's the task force itself is made up of over 100 professionals that work with older adults and are interested in falls prevention in some capacity. So some of y'all might be coming from the libraries networks, some of y'all might be from your local community-based organization. We have a lot of folks from injury prevention programs at hospitals, and all sorts of other different um, organizations, all committed to preventing falls and making sure older adults can live strong and healthy lives. So what we do as part of the coalition, we have meetings every other month where we get together and talk about some of the initiatives that we're working on. Um, these bi-monthly meetings also oftentimes include presentations from subject matter experts. So if you're not part of our listserv already, please reach out to me and I can get you added so that you can stay in the know about upcoming meetings. We also host trainings on the off months where we don't have meetings. This training today is part of that initiative. But the coalition is a great place to get connected to resources when it comes to falls prevention programming. There's also lots of opportunities to network and find chances for collaboration. And then, like I said, we have lots of subject matter experts that are experts in falls prevention. So it's a good opportunity to connect with them. And we also provide program support. So if you're trying to implement a falls prevention program in your community, joining the coalition can get you connected to the resources and the support that you need to make it a successful program. So, like I said, this is part one of a three-part training on data basics for falls prevention programs. Today, we'll be focusing on data to plan. The next training, which will be in May 7th, or on May 7th, is going to be specifically about accessing publicly available falls data. So, we'll have Rana Bayakli, who's the chief epidemiologist over at Georgia Department of Public Health, sharing information about how to access and where to go to access falls data for your community, your county, et cetera, in Georgia. And then the last part will be in June. The specific date is to be announced. We'll keep y'all updated on that once we have it finalized. We'll be focusing on how to use data to evaluate your falls prevention program. So like I said, if you join the Falls Prevention Coalition, you'll receive information and updates about those trainings so that you can make sure to get registered. So today, we have a couple main learning objectives. The idea is that after you leave today's training, you'll be able to recognize the different forms of data that you can encounter when you're implementing or designing a community-based falls prevention program. We're going to talk about different types of data, focusing on the difference between primary and secondary and qualitative and quantitative data. And then hopefully you'll be able to apply these basic principles for interpreting data in order to effectively plan a falls prevention program. And then the big focus of today, the big take-home message is that this kind of data that we're going to go over is really important when it comes to informing decisions about your program. All right. And I'll start going through this material and then we'll have a pause for discussion every few slides. If anybody has questions, feel free to unmute and jump in and ask, or you can go ahead and post or put it in the chat and I'll have Jill or Megan or Joshua or someone will be able to jump in and get my attention so we can pause to have that question answered. All right, so let's jump into it. So, very simple but very big question to start off with. What are data and how do you all interact with data in your day-to-day? So feel free to come off mute or post your answer in the chat and we'll get them read off. And while y'all do that, I just want to mention that this is something that confuses me a lot. Data is plural. So that's why it says what are data and what is data. That I still say what is data. I will say that throughout this presentation. I don't know why that word to me is one thing, not many. So y'all might have that struggle too. But does anybody want to come off mute and talk about how they interact with data in their day-to-day before we get into some definitions?
Well, for my job, I deal with data, property data. I manage rental properties, so there's software that I use which has a lot of data. And when I think of data, I think of just raw information.
Yeah, exactly. I think of it like that too, Venus. And yeah, as a property manager, you're definitely looking, I'm sure, at a lot of numbers, a lot of information throughout the day. How about for when it comes to falls prevention programs? For those of you that have been involved in falls prevention programming or just work with older adults in any capacity, would you be willing to talk a little bit about the data that you interact with on a daily basis? So I can speak for the Falls Prevention Coalition. One way that I was looking or interacting with data as I was putting this presentation together, um, I wanted to get an idea of what kind of content would be useful for y'all to review today in this training. So I was looking at different organizations that the training attendees were representing to get an idea of kind of what kind of data topics would be useful to cover. But there's lots of different examples. And then I see,
Mia.
yes, hi, Janet.
Hi, how are you?
I'm good.
Okay, so I'm retired, but I'm a certified Tai Chi instructor, and so I'm certified in a lot of different programs, but I'm also certified in Tai Chi for fall prevention. So when you talk about data, the data to me is that falls are the leading cause of injuries for adults that are 65 and older, and the statistics say that over 14 million or 1 in 4 adults report falling every year. So that is really important to me when I teach fall prevention keep them from falling because the statistics say, 1 out of 4, and it can change lives. I mean, if you fall and if you get a hip fracture, if you, that can be terminal. So is that the kind of data that you're looking for or that you're talking about?
Yeah, absolutely. That's I think Janet, that's like kind of the poster boy of falls prevention data, is incidence and prevalence, right? Like how much are people falling? And those stats that you listed off are really important because they tell us there's a big need, right, for programs that focus on falls prevention. Uh,
Yeah. Well, the interesting thing is that even though adult falls are common, they're preventable.
exactly. Yeah.
So it's just that what steps do we have to take, to make them preventable? What do we have to teach people,
Mhm.
to avoid falls? So we're trying to teach people that it's not necessarily inevitable that they fall, but it is preventable.
Exactly. Yeah, no, that's great. And thank you for joining us. I really admire the Tai Chi for falls prevention instructors. It's a really effective and important program. So thanks for
Thank you.
joining us, Janet.
Thank you.
So these
We
are
have
some
one
other,
Yeah.
more, Mia, in the chat.
yeah.
Sylvia piped in with that she collects membership data for senior
Mhm.
centers, faith-based organizations, and etc.
Exactly. Yeah, that's another really important example that a lot of folks deal with. So yeah, things like attendance logs, participant surveys, membership data, like was just mentioned, even notes from conversations that folks have with older adults, those that can be considered data, or that is data. Um, Fall incidence reports, observations, like if you're just in your community and you kind of are taking note of how many falls prevention services are available, or how many parks have walkable paths that are safe for folks to enjoy without a risk for falling. Those are all things that are also data. And then we have the more traditional forms of data, that I think people think of, statistics and things like that. So records from hospital discharge data or emergency room data. Those are where we get those stats like 14 million people or 14 million older adults have fallen this year, etc. So I think it's important to understand that data is broad, right? And it's not just those traditional statistics. All of these things are important information that we should be taking into account when we're planning programs. Um, so I like to think of data as pieces of information that when they're unorganized, it just looks like a jumbled up puzzle. And then once you start cleaning the data, analyzing it, and organizing it, you kind of turn it into information, and you can kind of create a complete puzzle that tells a story. And that information should help you see trends, patterns, relationships, and other insights that can help you plan a program. They're often telling us who, what, where, or why about a specific issue. And it's really important, and data is essential to helping us understand a problem and making decisions. So when we're talking about falls prevention programs, data is really important when it comes to the designing and tailoring of programs and interventions for falls. Data also helps us identify individuals that are at high risk for falling. And then they're also really important for helping us measure the success of a falls prevention program. So, what worked, what didn't, how can we improve so that the program can be more effective in preventing falls overall? So we're going to go into types of data today. We're keeping it pretty simple, but we're just going to talk about the difference between primary and secondary data, and then qualitative and quantitative. Um, does anybody want to take a stab at what the difference between primary and secondary data might be? And feel free to put it in the chat or come off mute.
I can try. Um, so
Thanks, Maddie.
primary data is something um, that you either export from an existing source that's available um, either to everyone or with special permission. No, sorry, that is secondary data, and then primary data is something that you would actually go out and collect via surveys or focus groups. Um, yeah, I don't know if that's the complete definition, but something along the lines of that.
Yeah, I that is exactly it, Unadi. Thank you for your help with that. It's That's the whole thing. Primary data is data that I'm going out and gathering myself as the person who's seeking an answer to a specific question or seeking the information. Um, and then secondary data is some data that's already been collected by someone else, and I'm just going and seeking answers to it from an already existing set of data. So primary data examples, that's when that can be, for example, if I'm collecting information about participants in a program that I conducted or that I was involved in. Um, you can collect participant demographic information like age, gender, living situation, race, ethnicity. Um, if I'm collecting my own data, I also might be wanting to look at health status and risk factors of participants of a program or people in my community. Can look at things like physical and mental improvement, behavioral and environmental changes, and this information would all be primary data if I'm the one that's going out and collecting it by having discussions with my participants or folks in my community or distributing a formal survey, things like that. And then some examples of secondary data sources, the Georgia Department of Public Health OASIS data dashboard. If I am going out and if I'm going to the website and looking for a specific piece of information from OASIS, that would be considered secondary data because that data has already been collected and analyzed by someone other than myself. EMS hospital records are also an example of secondary data sources. The American Community Survey, that uses census data to collect information about different uh, contexts throughout the United States. Um, County health rankings is another important data source when it comes to secondary falls data. And then census data, like I mentioned with the American Community Survey. So this is all data that's already out there and available. And then it's all accessible for you to go and look at the data and seek answers to your questions. And then, like I mentioned, we'll be having the second part of this training will focus on some of these publicly accessible data sets. Great. And how about the difference between qualitative and quantitative? Does anybody want to take a stab at this for definitions?
I can.
Thanks, Maddie.
Qualitative is typically things like interviews, surveys, focus groups, whereas quantitative is typically more mathematical, biostatistics, that type of thing.
Yeah, exactly. So, it's kind of numbers versus words, right? Quantitative data is any information that can be countered or counted, measured, or given some kind of numerical value. So these are quantitative data is stuff that is answered in numbers, whereas qualitative data is information that can be described and can't be numerically measured. So qualitative data is usually answering questions like why, how, what happened, whereas quantitative data is talking about how many, how much, how often, etc. So some examples of quantitative data would be in the falls prevention program context would be number of falls reported, right? So if we're looking at how many people have reported falling in my community over a certain amount of time, attendance, how many people attended my program or attended another program, pre-post survey scores, number of home safety modifications, number of referrals or services. These are all things that are assigned a numerical value. Whereas qualitative data is, like I said, more word-based. So this is stuff like participant feedback. An example would be, I feel more confident walking outside now. Descriptions of how a fall happened. Observations are also considered qualitative data. So if I'm participating in a program and I notice that folks seem to be more engaged with the balance exercise over time, for example, that would be an example of a qualitative observation. Conversations with older adults, and then open-ended survey questions and feedback from partners are all qualitative data examples. Yeah, Venus, I see you have your hand raised.
Yeah, I just thought about something. So the fire department, when you call them to help someone who has fallen, they have a specific code for that, and it's called Invalid Assist. And I was wondering if have you ever heard of being able to actually call the fire department in a certain county or city or municipality and just get a hard number as far as like an annual number of invalid assist calls?
I have a feeling that I think you're able to, and please, someone who has experience with this or has actually done this, please jump in. I know that people are able to get access to that information. I don't know if it's as simple as just calling them up and asking for it, but I know that it is possible. Does anyone have any insight on this?
I do actually. I work, I'm in Cobb County and I do ride-alongs with the Cobb County Fire Department CARES team. And so what that CARES team was formed to do was exactly what you're talking about. They take the frequent callers that are calling because of falls or inability to move around their home up and down the stairs, in and out of the house. And the folks just keep calling the fire department to come help them. So they compile that information and then they pass it on to the CARES team, which is made up of firefighters and paramedics, EMTs. And they visit the folks that are frequent fallers, frequent callers, and try to get to the root of their issues, why they're falling, and they bring resources into play. I work with senior services, so we collaborate together pretty well. But so I know that information is available and I can get it from CARES, but I don't know how you get it, from another outside source, but I know it exists.
Thanks,
Thank you so
Charlene.
much. That is amazing information. Thank you for sharing that.
Yeah, and Venus, I at a conference last year about aging. I remember attending a presentation with someone who was a 911 operator, and she was talking about um, sharing 911 data and information from falls related calls with people. So I'm going to go back and look at my notes from that presentation because I remember the whole point of her presentation was it's easy to get this information. So I can go back and look and then I'll reach out to you with some better information if that would be helpful.
Yeah, thank you so much. I could see how that could be very, access to that could be very useful.
Yeah.
I would also say that that is an excellent question to ask Rana at the May 7th webinar because she deals with the state data sets all the time and would be able to provide concrete ideas of how you go about getting access.
Thanks.
Mhm.
All right, so I'm gonna hand it over to Megan so that we can talk a little bit more about how y'all have encountered this data in your work.
Yeah, so thank you, Venus. This is a great transition to this discussion portion of the presentation. So if you all have some examples from your work on how you've been able to access the data or where you get it from, feel free to come off mute or stick it in the chat. So what data do you have access to that can include primary or secondary, qual or quant? Where do you get it from? Where did you collect it? And how did you use it? So Venus, tagging off of your comment there, you talked about the fire department and EMS data. So that is an example of where you can get that data and how it can inform your program or intervention. So if you have what they call frequent flyers or frequent callers, identifying that population and what interventions do they need, you can use that data to identify that. Any other examples of how you access data from your work or your position?
Deborah
I see.
mentioned hospital charts, um, want to examine infectious or injurious falls. Yeah.
Thank you, Joshua. That is a great example, Deborah. These hospitalization and emergency room records are great sources of data for falls. I also see another comment here, police and hospital data data for violent injuries, otherwise known as Cardiff. That is another wonderful resource to collect data. Again, tying back in that hospital and EMS partnership and how they intertwine. I see another comment. I'm required to collect data on clients before assisting them with home safety and fall prevention measures. We use the DONR as primary data. I also use an assessment called the Falls Efficacy Scale. In addition, I have secondary data from our case management from DDS. Those are all great examples of how data can be intertwined into your everyday work and how the data can help inform your interventions.
Megan, I was able to collect some primary data. I feel pretty cool being able to say that and know what it is
Yes.
now. I started attending a local AARP chapter meetings and subsequently joined, but just talking and asking and doing the fall risk assessment with the there's a fall risk assessment that was it's digital and I got it from the University of St. Louis, University of Missouri, St. Louis. And it's just a digital survey that I would do when I go into these meetings and have people rate themselves on a scale of 1 to 4. And so that was just an example of me going into the meeting and then actually talking about that. And everybody went through the surveys. And I did the same thing at a couple of faith-based, like church senior organizations. We just all did the little 12 question survey. And even though I did not see their data because everybody's assessment was personal, but at the end we discussed where they fell, based on the instructions of the survey. So
Thank you so much for sharing It is impressive to collect primary data. There are challenges intertwined with collecting data at a primary level, especially when you talk about checklists and surveys and things of that nature. And that is a great transition into our next slide. So I will pass it back over to Mia. Thanks, Venus.
Sure.
Yeah, thanks, Venus, and thanks everyone for contributing to that discussion. So we're gonna jump into talking a little bit about all right, now you have data, either you collected it yourself or you got it from somewhere else. Now, how do we use that data responsibly? And this is a really important thing to think about because at the end of the day, data is like a really powerful tool, right? And if we're using it for decision making, we have to be hyper aware that it can be used to harm instead of help people, if you're not using it correctly. So part of using data responsibly is making sure that it's quality data. So if you got it from somewhere else, making sure that that is a reliable data source. If you collected it yourself, making sure that you collected it correctly using the right methods. And then data can and has been used to stigmatize. So we want to make sure that we're not doing that, and that the people that the data is collected from, um, making sure that they're fully protected, and then making sure that we're collecting data for the right purpose. So when it comes to identifying quality data sources, there's two big things that you want to look for. You want to make sure that it's a reliable data source and that it's valid data or valid data source. So reliable means that the data source is accurate, it's trustworthy, and it's being collected using rigorous methods, and that it's been double checked to be free from errors or any potential biases. Um, when we think of reliable data sources, usually government sources, so websites that end in .gov are going to be trustworthy and reliable. And then data from academic centers too, or websites that end in .edu. Those are usually trustworthy. And then peer-reviewed studies are also reliable sources to look for data. And then validity when it comes to data sources means that the data is actually measuring what it claims to measure, and it's directly relevant to the problem at hand. So we want to make sure that if a data source is claiming to have data on falls in Cobb County, then the falls data is actually from Cobb County, and not a, average of the entire state of Georgia, for example. So examples of reliable and valid data sources. This is census data, reports from the CDC, school health assessment, peer-reviewed studies, in data from evidence-based falls prevention programs. These are all reliable and valid data sources. Unreliable sources would be data that's been collected using questionable methods. So maybe the methodology that was used to gather that data was not very rigorous. And that could lead to data that has errors and biases, right? So you're seeking answers from this data, and the data might be telling you something that is different from reality. You want to be very cautious of that. And then invalid data sources are those that don't accurately measure what they claim to measure, and they provide misleading or irrelevant information. And that can be in the form of outdated studies, right? So if I'm looking at a peer-reviewed article, okay, it's peer-reviewed, so that checks for perhaps reliable and trustworthy source, but it's a study from 1982. that might not be very relevant to a program that I'm planning today in 2026. Um, Unreliable websites, um, random.com information or data from random websites ending in .com that don't provide a reliable source. Um, and then you always have to watch out for biased sources when it comes to data. Um, can we think of, well, actually, let me continue on because I want to make sure we have time to get to the discussion at the end of this portion. Any questions about unreliable, um, invalid versus reliable invalid data sources before we move on to the next slide? All right. And hearing nothing, I'll go ahead and move on. Another important thing to consider is, are you choosing the right data for the question that you want to ask? Um, Coverage and representation of the population that you're seeking information from is a really important aspect of choosing the right data. If I am trying to plan a falls prevention program in my community and I want to collect data um, from my community to help me plan the program, I want to make sure that I'm gathering data from a population that can effectively reflect my community, right? So the best case or the best situation for that is I have data directly from my community. If that's not available, then I'm collecting data from a community that has similar characteristics than mine. Um, Timing is also really important. If I already have information from my community, but again, it was maybe collected 10, 15 years ago, um, communities can change a lot in 10, 15 years. So is that timing of the data collection going to be a barrier that makes that data unusable? Probably in this situation. And then geographic area is also really important. The data should be representative of the specific geographic location where I'm trying to implement my program. And this is all important because we want to have an accurate picture of our community or the group of people we want to do the program with, because that will ensure that, or that'll make it more likely that our program will be effective. So anytime you're dealing with data, it's really important to think about data justice. And data justice really comes from the fact that data has been historically used to used for harm. It's been weaponized specifically against marginalized communities, communities of color, low income, migrant, and other stigmatized groups like older adults. And that's been a really important way that has reinforced oppressive systems and caused misrepresentation of communities. Been used to place blame or label different communities, and then data has also been used to over surveillance these stigmatized communities, and it's often been used to promote deficit-focused narratives. So those are narratives that only point to the quote bad things in a community. So the idea of data justice is that when we're using data, we need to be using it to capture knowledge and lived experiences that are community-centered and community-driven to kind of counter those oppressive data practices that have been used in the past.
Gonna ask, has anyone ever experienced any problems with data and data justice that we just discussed? How data might have been used for misrepresentation or blame or deficit focused in your work or kind of in your communities? Have you experienced anything with older adults and how data may or may not be representing them in a popular light or in a positive light?
Has anyone heard of this idea of like a deficit focused or deficit based versus a strengths based narrative, and how maybe data about older adults has been used in either or one of those?
Like one of the things I think of is older adults in the workforce and whether or not they're like one of the deficits is technology-based deficits where people often view older adults as not being able to handle technology or do certain things, and that's a very deficit focused um, discussion.
Yeah, Venus says that she's heard of that. Yeah, so the idea is that when we are this, and this isn't to say that you can never kind of use or highlight data that shows perhaps a challenge that a community has. It's just saying that if you are to do that, it's important to provide context surrounding why that challenge might be occurring. And when possible, rather than highlighting the deficits or challenges of a community, instead highlighting the strengths and the resilience factors that that community might have. Because a lot of times we can leverage those strengths and resilience factors to uh, help to help find a solution to a problem like falls.
Yeah. I think it's specifically like one deficit focused would be older adults who don't exercise are more likely to fall versus kind of reframing that to being older adults who exercise and maintain their core balance are less likely to fall. So it's the reframing to being more of a positive that older adults can and are able to basically maintain their balance into older age. And there's definitely things that they're able to do. So that would be um, taking a positive framing instead of a negative framing.
Yeah. And oftentimes it's all about framing. So if you do see something that is deficit or a statement that's kind of focusing on a deficit or a challenge, there's usually going to be a way to flip it so that it highlights and focuses the strength. So just to kind of reiterate, data justice is when you use data as a tool for healing and action, not judgment. This is data that makes community-driven needs, challenges, and strengths visible without adding to further stigmatization or generalization of an entire group. It's also about using data that's accurately representative of a community and doesn't leave anybody behind or in the shadows. And it also is something that is important for promoting community self-determination. And again, it's emphasizing strengths and protective factors, not just risk. Um, Privacy is also a big important part about using data responsibly when it comes to falls prevention programs. We've talked about how a lot of times we're collecting participant information. This can be stuff like, how many, this can be things like how many times have you fallen? Have you fallen? What injuries did you experience? It's all personal information that's protected under HIPAA, which I can't remember what HIPAA stands for, but it's like basically everyone has the right to have their health information be private and confidential. So if we are collecting that information that falls under HIPAA, we want to make sure that we're keeping it stored privately in a place that nobody else can access it. Um, we want to make sure too, anytime we're collecting data from people, so this would be in the case of primary data, when I'm going out and collecting it myself, whoever I'm speaking to and getting data from, they have to be fully aware and understanding of what the data is being collected for. And they also have to agree. And there's lots of different ways to collect informed consent. Um, it can be just by making sure that you explain why you're asking these questions and what you're going to do with the answers to their questions, and then getting a verbal agreement that it's okay. So, um, after explaining what maybe if I'm doing a survey or just talking to participants of a class, if I explain why I'm asking the questions, and then just isn't as simple, is it okay if I record your answers to these questions? That works as informed consent. If you are ever going to share data from a participant, um, you have to make sure that the data is de-identified, meaning you're not able to figure out who provided that data. So no names or other identifying characteristics are attached to the data so that nobody knows who it came from. And then if you are going to share a participant story, perhaps you did a class, you conducted a class or a training, and somebody afterwards came up and said that they really enjoyed the class, and that it helped them, with another situation. If you want to share that as a success story about your program, you just have to make sure that it's okay with the person that gave you that information. Venus, you put in the chat, can you confirm that HIPAA wouldn't apply to anonymous surveys? Sounds obvious, but Jess would like to confirm. Yeah, no, and I don't think that that is super obvious. If I think HIPAA is de-ident so a person's name can't be attached to the information. So if it's an anonymous survey, then there's no way of knowing who that information came from, and thus that would comply with HIPAA. So thanks for that question. All right, and yeah, Unadi, I see you have your hand raised as well.
Sorry, just a follow-up question on that. So if I have information that does not have the patient's name, but it still has like a few demographics, like let's say address or race, ethnicity, and age, that like just three of them together could potentially identify that person even without the name. Um, that would still, even if that's anonymous, that would still be subjected to HIPAA law.
Yeah.
Okay.
So there is one important component of HIPAA that people need to take into consideration, and that's that it only applies to those covered entities. So there's a subset of hospitals, clinics, doctors' offices. That's who HIPAA is designed to kind of help to navigate what isn't allowable. The rest of us kind of adhere to the general principles of HIPAA, but it's not like we are not under the HIPAA law as an organization. To your point, we don't necessarily want to use identifying information in any sort of disclosure of information that would lead it back to linking it directly to them, but that's more of an IRB or I guess for research purposes. It would be more of an IRB related issue or a confidentiality related issue, but not necessarily a HIPAA. I don't want to like totally go off the track of this, but if you're trying to use HIPAA, just realize that there's a whole bunch of other information around it that would make it apply or not apply.
Thanks,
Yeah.
Jill. That's very helpful.
Yeah, and I think we wanted to mention it because HIPAA, like I mentioned earlier, it really is about protecting people's privacy. So you might not have to adhere directly to the HIPAA standards if you're just trying to plan a falls prevention program, but you do want to always, when conducting research, make sure that you make sure that it's a priority that you're protecting people's privacy and their private information.
So after those last few slides that Mia shared and some things that Jill brought up as well, what challenges can you think about in your work that you've had with data sources? So that include like if you've had any issues with unreliable data, have you seen any unreliable data when you were researching something? Did some website pops up and kind of put up a red flag, like, I don't know if that is reliable and if I should use that? Or have you had any trouble accessing data? Are there any paywalls or any barriers to accessing any of these primary, secondary, qualitative, or quantitative data? You're welcome to put it in the chat or come off mute. Yes, I see in the chat sometimes they need to be purchased. So unfortunately, some databases do have a paywall tied with them, and that creates barriers and limitations to accessing those data sources. Any other challenges that you may have faced when looking into data sources?
As far as the primary data that I was mentioning, collecting at just different programs or workshops, I would say that a challenge would be getting everyone, getting the most people are getting everyone to actually complete the survey. So trying to think of ways to incentivize or make it really simple and easy for them to do. Perfect example, maybe let's just say there's 100 in attendance. Well, maybe only 40 or 30 or 40 people will actually do the ending survey, whether or not it's because they left early or they forgot or whatever. So I would just say that came to mind as far as a challenge in collecting data.
Thank you for that. That is a big one, especially when you're collecting primary data through surveys, is just getting people to complete the survey or complete it in full, because sometimes not completing that in full affects your results and your ability to inform that program. So that is always a challenge. So yeah, like you said, Venus, keeping the survey easy to read and short may be able to avoid that challenge, but definitely a challenge that I hear of often. I see one in the chat for qualitative data, having space to write down the comments and thoughts immediately after the conversation or have a transcript of the conversation. Yes, so sometimes when you step away from that conversation, you might not quite remember all the things that were said during that discussion. So it's important to be able to write it down immediately, but sometimes there's barriers to that. Sometimes things come up or you get pulled into another direction, so that can create a bit of a challenge as well. Another one I see in the chat here regarding skills or surveys, people might read wrong or rate opposite what they really feel. So putting a 1 instead of a 5. Yes, that is very common as well. People are reading these quickly, right? They're usually on the way out at the end of an event and they're just filling it out really quickly and maybe not reading it in its entirety. So those mistakes can happen. Great. Thanks so much for your feedback here. This is always really helpful to hear, and how we can overcome those challenges, what exists and how we can overcome them. I will pass it back over to you, Mia.
Thanks, Megan, and thanks everyone. So we're going to get into the specifics of using data to plan falls prevention programs. So before we start implementing a program, we obviously have to figure some things out. We need to do a little bit of planning. And that planning is, as we've gone over, it's going to be informed by data. When we are going to, before we even start collecting data, we need to know a couple of things. We want to figure out, or we want to know what we're going to be using that data for, or what questions that data is going to answer. In the program planning process, oftentimes we want data to let us know the needs of a population or of a community. We also need it to help identify what kind of falls prevention program is going to be right for that specific audience. If you're going to use an existing falls prevention program, then you'll need data that'll help you kind of tailor it to fit your audience. And then when it comes to evaluating the program, you are going to use and collect and use the data to tell you whether your program reached the correct audience that you were going for, and it'll also help you identify if a program worked or not. So when it comes to planning, before you're starting your program, you want to decide what was the target population. So who will this program serve? You want to know the setting or where the program will take place. You want to know what your program's actually going to do. So what are the activities that are involved, and what kind of problem or need this program is going to address. And then you also want to think about what success is going to look like after the program is finished. So when it comes time to identify your target audience, you are going to ask questions like who lives in your community. You want to know who is most at risk. Who are you or other programs already reaching? So who are the folks that are already connected to programs? Who most wants or needs the service that you're going to provide. And you also want to try to figure out who's being left out and why. And these are all questions that can help you determine who your target audience should be. So when it comes to figuring out who lives in your community, you want to look at data like age distribution, gender, race, ethnicity, income levels, living situation. All of these demographic data points can help you figure out who this program should be serving. And you can get this information from intake forms, from your own organization or a partner organization. You can also get it from community profiles. These are things like the county health rankings. You can find data you can find demographic data about your community from the census as well. Or you could just think about, what you already know about your members. Who is it that you're seeing interact with you or your program frequently? What do you know about them? And is the program that you're planning, should it be serving them? You also want to think about who's most at risk. So this is when you're going to be looking at risk and needs data from hospital records, intake questionnaires. conversations with participants, observations. You can look to those sources to find out who has a history of falls, who maybe is encountering mobility or balance issues. You can observe, who in your community is using assistive devices like walkers, and then who has chronic conditions and perhaps who has a fear of falling. And these are all data points that can help you answer who might need this program the most. When it comes to thinking about programs that are being implemented or have already been implemented, you can look to see who is attending those programs to find out who's already kind of been reached with existing programming. This can be data from current participants, so who's attending existing programs, kind of what are the patterns in attendance, like who are those that are coming regularly versus who stop by once or twice. And by looking at who's currently engaged and who isn't, that can kind of show you gaps in reach, and could tell you, okay, these folks show interest in that they've signed up for the program, but they only came once or twice. So why do we have that gap in reach, and how can we maybe address it in the program that I'm planning now? For identifying folks who need the program the most, you can look at community data, participant surveys, informal conversations, feedback from caregivers, input from partner organizations. And then you can also look at those secondary data sources that I mentioned earlier, to see maybe who's falling or what areas have high rates of falls. Or you can conduct a form. You can go out and collect your own information or data by doing a formal needs assessment survey, or you can just have informal conversations with members and partner organizations. Needs assessment surveys are really are really helpful for asking, or for letting, or sorry, understanding who or what are the needs of a specific population. So in the case of falls prevention programs, they can help answer who's most at risk for falling, what factors are increasing risk, what challenges maybe are older adults running into when it comes to staying free of falls, what support or resources do they currently have, and what support or resources are missing. You can do needs assessment. You can create your own needs assessment survey and distribute it yourself. You can also analyze existing data to try to identify needs for a specific population. And you can also get the answer to these questions by having conversations with your members. An example of a needs assessment that was done by looking at already existing EMS data, the Broken Arrow Fire Department, which is a city in Oklahoma, they looked at EMS records to determine fall-related injury characteristics. So they wanted to understand the demographics of the folks that were falling, how they were falling, where the falls were occurring, and what types of injuries they were getting. So they looked at EMS reports of falls or of responses to fall-related incidences, and they used the data from those reports to understand the answer to these questions and inform, to help them guide them in terms of what kind of falls prevention programs they could use in their community. Um, the target, when you're thinking about who your target audience should be for a program, you should also be considering who is getting left out of existing programming, by looking at maybe who can't participate and figuring out why. You can make sure that you're removing any barriers to participation, so that those folks are able to get access to the programs that they need.
So in relation to the last couple of slides, can you all think about any challenges you have had when it comes to deciding your target audience? So what were you able to do to resolve those challenges, and how? How can you use data to address these challenges, and what data would be helpful? You don't have to answer all those questions at once. If you just have one comment for one question, we can start with that. But any challenges that come to mind when you were deciding a target audience? So some things to think about are understanding who lives in your community and who is most at risk, who wants or needs the program, and who's getting left out, like Mia shared, of existing programs, and understanding why they can't participate and what barriers may you be able to knock down to get participation.
For those of you that have a program ongoing, what type of data did you use when you were developing your programs to help inform your decisions? Was it conversations? Was it looking at falls?
This is Marie with Get Up and Move LLC, a certified Tai Chi authorized instructor. So when I look for my audience participants, I'm looking for people who are 60 years of age and older, and for people with disabilities. So that's what we look for. And a lot of times when we get those people that has a disability, they're usually in a wheelchair, they're usually on a cane, or they're usually on a walker. So that's what we look for when I'm establishing looking for my programs.
So, Marie, just a follow-up question. How do you know that there's sufficient numbers in any given area for you to start a program? Is it that there's one person there? Like, how is there a sufficient population base for you to start a program? Or how do you know that?
I somewhat had a little advantage because I worked for one of the AAAs for a long time, and I retired a couple of years ago. So I somewhat had an advantage with the area where I worked. So a lot of times I was looking at the senior centers. I do know that, and I'm looking at the YMCA's because they provided services for older people and people with disabilities. And I looked at the churches, and so that's what I had a little advantage going forward when looking for my participants. And of course, by word of mouth and advertisement.
Those are some great examples there with taking some information from the local churches and other local community organizations and using that information to guide your program and to identify who that target audience may be.
So similarly to the person who just spoke, initially I was a personal member of a senior center. So I went there, started out going there just to get lunch for my mother and I, and got familiar with, how active it seemed. So that was the first, idea of, numbers as far as participants, because they were quite active and had quite a busy schedule every month because they published the activities every month. So that was my first inkling to, wow, these people come out and participate. Um, and that was at the Bowden Senior Center in East Point, Georgia. And that sort of inspired me to do the same thing at a couple other places, and so the people were there. So it's just like, a program it would be appropriate because it just, I can see that they participate in large numbers. So it was kind of that simple.
That's another great example. Thank you for sharing. Yes, using your local senior centers or community centers as a resource to identify those target audiences. We had another comment in the chat, looking where coalition members are offering programs to help determine gaps. This relates very closely to the previous idea. So this also includes hospital data, who has higher fall rates, looking in terms of ages, locations, etc. So yes, those are all great examples of using resources that already exist. If you're limited in your ability to complete a needs assessment or survey data yourself, using the resources around you to continue the work. Another comment here, love the use of observational data at local areas and using counts of ongoing programs. Yes, that is exactly what we pulled from some of your comments here. So thank you everyone for sharing. We appreciate kind of getting more insight from your work on the ground. I will pass it back over to you, Mita.
Oh, thank you. Yeah, I want to just emphasize the opportunity to leverage the area agencies on agings in your area, as well as senior centers, community centers, YMCAs. Those are all places that can usually are willing to share information that can help you decide on a target population for a program. And really, they can help identify a program setting and all the other things you need to know to plan a program as well. Data can help you decide where to offer your program as well. Sometimes we're kind of limited in where you can have a program if you have one space that is available and that's maybe part of your organization and you have to have your program in that space. That's definitely a common situation, but sometimes you have a couple different options and you want to look at participant location data and also data about access and transportation to kind of help decide where you should have your program. So if you look at participant addresses, zip codes, you can see where folks are kind of located and make sure that your program takes place somewhere that they can get to. Sometimes you work for an organization that has a specific service area, so you want to make sure you're selecting a location that falls within that service area. And then you can also get participant location data from partner organizations. So like we mentioned, senior centers, triple A's, sometimes senior housing or other types of housing facilities can be helpful with that as well. And then for access and transportation data, going in and asking participants, either through a formal survey or through conversations, how do you usually get here? That can be helpful in figuring or in letting you know whether or not folks are going to be able to access or get to your program. And then feedback from staff and partners is also really helpful. If you're hearing people say, I think this program has potential, we maybe are having low attendance rates because most folks are taking the bus to get here and there's not a bus stop nearby. That could tell you that maybe you should relocate to or have your program be somewhere that's closer to a bus stop or another route. Facility and environment data can also be helpful. So that means accessibility. So is the location or site that you want to have your program at, does it contain fall risks in the site itself? Is there the appropriate accessibility infrastructure like ramps versus and elevators versus stairs for folks that might have mobility? differences. Lighting, is the space going to be big enough? Those are all important things to consider. Availability, if you're having a program take place at a partner location, do we want to make sure that that space is going to be available at the times where it's needed for your specific program? And you can get this information from site visits, and staff and partner knowledge would be two examples. Um, and then community context is also important to know about when you're planning a program. Are there already services or programs existing in a specific place? If so, do we maybe want to take our program somewhere else where it could reach a group of people that doesn't normally have access? Um, and then there's also community-specific characteristics that you want to think about. Is there a specific leader in your community that is an important voice that you can kind of get on board with your program so that they can share information about it? Is there a specific place in your community where these kinds of programs are already taking place, that people are willing to get to and able to get to? There's always things that are kind of specific to each community, that you should consider when you're trying to figure out where to have a program. So we've talked about using data to identify a target audience and a program setting. Now we're going to talk about deciding program activities. So what program are you actually going to implement? The first step to this is, first you want to look at the evidence-based falls prevention programs that are already out there. And evidence-based programs are really important because those are programs that have been tested and proven to be effective. So there's been a scientific research process that has taken place to test the program, and it concluded that yes, if you implement this program and adhere to the program guidelines, you should have positive results. And they determine this by being evaluated and validated by experts in the field of falls prevention. They usually have a guide or a manual or some sort of training material that has to be used to implement the program. And part of the testing in conclusion is that if you implement this program in a different site or setting than it was originally tested, you should receive similar positive results. So evidence-based programs are really important. And by the way, we'll be emailing these slides out to everybody, so you'll have access to these links. But these are a couple of evidence-based falls prevention programs. Some of y'all might have heard of these. Matter of Balance is a big one, Bingo Size, and then Tai Chi for arthritis, like was mentioned earlier. Stay Active and Independent for Life, or SAIL. Stepping On. These are all evidence-based programs. So they've been tested and proven to be effective if implemented correctly. And I got this list from the National Council on Aging's Evidence-Based Falls Prevention Programs webpage, and I have that linked in there. So once y'all get this, you'll be able to access that. And then just because we are running out of time, I will go over this quickly. Some of the data that you want to look at when you're trying to figure out what evidence-based program to implement, you can look at risk and needs data to kind of figure out the needs of your target audience. You can look at what activities people will actually participate in. So has there been a program that's been implemented with this specific group in the past that was particularly successful? That could tell you what kinds of activities participants are interested in. And then you also want to consider barrier and access data. So timing, conflicts, transportation, cost, cultural relevance. These are all things that you want to consider when thinking about why people might not be participating, because then we want to choose programs that kind of remove those barriers. And then lastly, just kind of as an introduction to the program evaluation training, which will be happening in June, before you, even though the evaluation itself of a program is going to happen during and after its completion, when you're in the planning stage before implementing, you still want to consider kind of how you are going to evaluate and determine whether or not a program is successful. So before the program starts, you want to know how you're going to figure out whether your program worked. One thing that you can look at is reach and participation. Who participated, who completed the program versus who dropped out of the program. Did you reach the intended target audience? What were the barriers of completing the program? And how often did people attend? Those are all important things for determining whether you reached the correct group. And you can get that data from registration forms, attendance logs, follow-up conversations with participants. And then another important way to identify program success is beforehand determining what kind of short-term outcomes versus longer-term outcomes you want your program to have. So for the folks that attended and completed the program, perhaps I want to measure how much their knowledge about falls prevention increased. Or perhaps my program is trying to improve their confidence or lessen their fear of falling. And then another potential short-term outcome that we might want to measure is self-reported behavior changes. So asking participants before and then after about steps that they take to decrease their risk of falls and seeing if the after responses show any increase in behaviors that keep folks safe. And then this is falls prevention program. So ultimately, the long-term goal is going to be that there was a reduction in falls for those that completed the program, or perhaps the improved balance or mobility. And these data or these outcomes can be measured through pre and post surveys, questionnaires, verbal feedback. You also sometimes, when it comes to those longer term outcomes, want to have follow-up surveys that are 6 months, a year, 2 years, etc. after the completion of your program. Sometimes those can be conducted through phone calls with participants. And then also partner information can be helpful, like things like hospital and EMS data can show you whether or not there was a reduction in falls before or after your program was implemented. So I know I zoomed through those last couple slides kind of quickly. Just a reminder, you will have access to these slides, and we're happy to meet and talk about any of these, any of the content that was covered today. But I'll just pause, and we have 2 minutes for any questions, or perhaps any other discussion points that y'all want to share in terms of your experience with this kind of data collection. So did anyone have any questions about the material that we covered today?
Is there anything new or anything that you would like more information on in the future when it comes to data?
I would like information on how a particular program gets to be, is there like a process by which a program gets to be evidence-based or categorized as evidence-based program? Is there a process?
Yeah, so usually it takes a lot of research to get a program to go from just a program all the way to an evidence-based program. And usually it goes through different stages of efficacy and then seeing if it does actually have measurable change in falls reduction over the course of time. And so that's a very lengthy process in kind of the research realm as well as program evaluation realm.
Great, thanks.
Yep. Any other last questions? And we can drop that link in the chat for people for the evaluation, potentially.
Yeah, I'm just trying to pull up the link so I can put it in the chat. Yeah, speaking of challenges with data collection, someone mentioned getting people to complete surveys. We have an evaluation survey here that we hope that y'all will fill out. They're really, really helpful in terms of understanding whether or not y'all whether or not the training was helpful and what we can do to make future trainings more helpful for you all. So please take a minute to fill out that evaluation survey. Tell us how we did. If you have any questions, you can email me. My email is right here on the slide. And then I'll be sending out a follow-up email with the slides attached, and then a couple links to some of the resources that we mentioned, as well as links to register for the upcoming trainings. So with that, I just want to say thank you guys again for attending. Hope this was helpful, and we hope to see you for our May 7th training.
Thank you all very much, and it's extremely helpful.
Thank you. I'm glad to hear that, Marie.
Thank you, everyone.
Thanks, everyone.
Thank you, Mia and Megan.
Yes.
I finished my survey.
Yeah.
Thank you, Marie. Thank you, Venus.